Good evening and welcome to our session on frailty and nutrition. It's my pleasure to welcome you this evening to what I hope will be a really engaging and insightful session. We've got a couple of really excellent speakers, so I'm going to keep my bit short. My honour to really introduce and chair the session today. I'm Shailen Rao from Soar Beyond. I'm a pharmacist by background. I looked at the names of people registering, and there are lots of familiar names, but also lots of new people, the majority being pharmacists, but also a special welcome to the dietitians, given that we do so much work up as an organisation in malnutrition. It's a real pleasure to have you, and really good to be involved in what is effectively a virtual multidisciplinary learning session, so long may it continue. As I mentioned, I'm a pharmacist by background, and in our organisation really focuses a lot on clinical pharmacy in particular, but in a way that integrates into the whole system. And I've had a number of years experience myself working in the NHS, and a couple of the speakers who you'll hear from today, I've had the pleasure of knowing them for, well, I won't say how many years because it will kind of date all of us, so blanks on that one. So the session today, we're going to be, the objectives are really to think through the considerations when conducting virtual reviews of frail older patients. And my God, we were just having a chat with the speakers. The care home agenda is really taking off. The frail elderly are right in the centre of the target board, really, in terms of who we need to be doing more work with. So really pleased to be able to bring something that's really timely, and I hope you'll find very on message in terms of giving you some practical skills to be able to manage this group of patients. Implementing the best practice, so we're all of in the I2I network, which stands for Insight to Implementation. So Insight you'll get plenty of today, but our focus is equally on the implementation. So points 3 and 4, they're really about the practical stuff to help you make it happen for yourself in practice and do the amazing work that you do. It's not a Thursday, it is 8 o'clock, it's not a Thursday, so I really applaud all of you that are in the front line, our heroes. We kind of applaud you every day in the work we do, really, not just on a Thursday. That's the agenda on the screen. I won't labour the point. On your panel, you'll see handouts. You can actually download that agenda from there as well. So in terms of just giving you a heads up on the engagement, that's a little visual there on the screen with your little panel. And what we're going to be doing is recording the session during the, well, we're going to record the session, and you'll be muted and cameras all turned off. We've got a large audience already logged in, so that's just to keep it simple. Please do ask questions right throughout. There's a questions tab on the panel, as you can see on here. This little circle there, with the arrow there rather, and we'll be collating the FAQs throughout this webinar, and we will send out an FAQ section after the event as well. And of course, the recording will be available for you to access should you wish to do so. To keep it interactive, we don't want to really be talking at you. There will also be some poll questions as we go along, and talking of which, we're going to go to the first poll section. So it's a simple question, really, as much designed to help you kind of get to grips with the technology. So in a second, I'm going to just put that question up for you, and if you wouldn't mind just answering simple yes and no, and then I'll see the numbers coming up, and we know it's working. So very interested to see actually how many of you are already engaging in a virtual kind of way. Right, almost neck and neck. I'll just let it run for a few seconds while people find the buttons. And that's been a seismic shift, hasn't it, really, this shift to online, amazing things that are happening online that we would never have dreamt of, really. Okay, just a couple of seconds because the numbers are still coming in. Okay, brilliant. So I'm just going to click the share, and that should come up on the screen, and you can see 59% yes. So the majority, a bigger differential than we had in Brexit, 59% to 40%. So by my reckoning, that's a huge majority now. But it is incredible, really, to see. So yeah, thank you for that. And we'll come back to polls during this the session as well. Great. So let's move on. Key challenges in managing frailty. massive issue. And it reminds me of one of my favorite quotes from one of my favorite people of all time. And what a perfect moment to perhaps reflect back on what he said. So it was Mahatma Gandhi who said, a true measure of any society can be found in how it treats its most vulnerable members. And of course, one of the most vulnerable groups we can think of right now would be the frail older patients. So I guess, it's my view would be from a healthcare perspective, we're doing amazing stuff, but the needs suddenly gone up with so many people kind of self-isolating and shielding and all the rest of it. How do we make the most of it? So that's really our focus, to kind of augment the amazing jobs that you're all doing with this vulnerable group. But I think in the fullness of time, I'm sure we'll look back and kind of take stock of how did we manage. And I think, I'm not sure about the whole country and necessarily the politics of it, but certainly from the health system, I think we'll be very proud. So hopefully we'll help you today to kind of push it further in that direction. So I'm going to hand on to our first speaker. So Lily, welcome. Thank you for joining us. I know it's been a manic day for you, hectic care homes. For those of you that haven't met Lily before, an absolute superstar in the world of pharmacy, consultant pharmacist at Guy's in St. Thomas, very much a specialty in kind of frail older people, frailty and polypharmacy. So that's the bag. So welcome, Lily. Great to have you along.
Thank you. Thank you very much, Shailene, and thank you everyone for joining in. So I'm just going to go through some of the key principles relating to frailty and what we need to be considering, not just only for frail older people, but in this time of COVID. So as you can see on the screen, I'm just going to talk mainly about the key aspects. So what are we really thinking about in this COVID time? Number one is we need to think that we need to reduce spread of infection. That's a big priority. We need to move away from long-term medicines optimization, and we need to be thinking about basic medicine safety, supply, and all those things. We need to ensure that we're still putting patients at the center of care. Shared decision-making is even more important now, and we need to tailor the care to the individual patients. We are going to be having a lot of ethical dilemmas because things are not going to be so straightforward because we've never been here before. And so it's thinking about the framework to follow. There's one by the RPS, and also just looking at the wider multidisciplinary team for support. And we also need to be thinking about the impact of what we're doing on other colleagues' workload. So this is not a time to be thinking too much about numbers of medicines. Now, if we need to reduce the numbers because somebody is unsafe, or to reduce a workload like we have in care homes, we need to be thinking about that, but not the long-term medicines optimization scenario. We need to know that even though with the frail old people, research is limited, it's even more limited now in COVID. We need to use existing frameworks. We have loads, so the stop-start tool, the Scotland tool, they're still very useful. And then we just have to add our clinical judgment and our expertise, as well as the patient, in terms of deprescribing. We need to be thinking about deprescribing only when there is very low risk. Now, as we're moving from face-to-face, which is what was ideal and gold standard, moving to telephone and video consultations, we need to be aware of the limitations that brings along with it. So for example, we don't see the verbal cues, we don't see the people's environment, we don't see all the things, we can't build trust and rapport. It's a bit difficult with the devices and all people who are hard of hearing and all those limitations. So we need to be listening with our ears, with our eyes, to detect potential risk. We need to be asking more questions and doing a bit more to find if there are any red flags. So basically, we need to be erring on the side of caution in terms of our interventions. We don't want anything that will bring too much contact. In terms of what needs to be monitored, that really is a big part. What can we actually monitor? So usually there's guidelines around monitoring. The SPS have produced just monitoring for many drugs. They've looked at COVID specific one, is all on the website. And then rather than doing blanket, we might have the list of people to change, but actually the monitoring should be done on an individual basis. Just thinking about some of the things I talked about, the COVID limitations. We need to think what's essential monitoring, what's ideal. Why are we monitoring? What's that going to add to, the patient's safety or in terms of outcome? Is the risk of monitoring bigger than the risk of not monitoring? How is that going to impact on other colleagues like GPs? Are they going to be having to do all these tests unnecessarily? I think basically we need to think about spread of infection. We need to think what would happen if we don't monitor this patient now. Can we delay it? Can we omit it completely? We need to be asking those questions, and what should happen in the meantime. So going straight after monitoring is looking at red flags, and is what do we need to know in terms of the red flags that we need to let the patients know, we need to let the patient tell us. So think about BP, do patients have their own monitoring? Is there someone else who can do it? And I guess finally is looking at health and social care staff and other colleagues that we need to refer to, even though we can't be there to see them to attend to our patients face to face. Yeah. Yeah, so I mean, I've kind of literally covered, so it's just kind of highlighting some of those things I've said. And again, just adding a little bit about the social care and healthcare referrals. Things like medicines delivery, it's things like making sure people have enough to drink, enough to eat, and all these things have implications for old people. And just looking at specific drugs where we need to have enough food and enough hydration so that we don't cause more harm than good. Yep.
I think Shailen's on mute.
Thank you. I was talking to myself for a second. Thank you, Lily. So we'll come back to Lily in a few minutes. We're just going to get an overview from the speakers, and then we'll kind of delve into the case study. So we're going to kind of spend most of our time today in 2 case studies with both of us is working together. Before I hand on to our next speaker, Anne, I just wanted to take a minute or two just to set the context, really. So looking at malnutrition, as I said at the outset, the majority of our audience today, I think, are going to be pharmacists with also a significant number of dietitians. And one of the obvious questions would be, well, why are we talking about malnutrition to pharmacists? So I guess perfect way to perhaps answer that question from our perspective and set a bit of context is to look at a couple of NICE guidance. So it's not us really saying that. And I think the first 2 link up here. What we're really talking about and what NICE, this is the quality standards from NICE, this is from 2012. And it's a great blueprint of what the health system as a whole needs to do to get better outcomes for malnutrition. Well worth a look. It's still valid, although it was released a while back. And unfortunately, I don't think enough has changed, so it is very valid. And 2 points I've underlined there. First of all, it's for all care services and kind of all healthcare professionals, and it needs to be a multidisciplinary approach. So especially now when you look at PCNs and the multidisciplinary world that we're entering already, coupled with COVID and the kind of need for everyone to work a little bit beyond their scope, but do it safely. That's why we think it is so key and so of a moment that we should be doing something to help pharmacists, but also hopefully also with the dietitians there to support them. So we're certainly not looking to make pharmacists into dietitians or to replace dietitians, but there's some basic knowledge and insight that actually hopefully we can raise the skill level a little bit. And actually that's the next 2 points, that this should be read and implemented in line with national and local guidelines. So we'll be talking about national guidelines and evidence because that's all we can do, but we're very cognizant of any local guidelines that people need to adhere to. Anne's an absolute expert on this, and we'll be covering some of the national evidence and guidelines. And also it's dependent on all care professionals, and they need to be trained and competent. So we're kind of giving this boat, if you like, a push in the right direction. It's all we can do in an hour. The second thing I just wanted to flag up, because it's very easily confused for those who are not familiar with it, we'll be talking about nutrition support. And as NICE defines, oral nutrition support includes fortified foods, includes SIP feed. So we will be talking about a range of options. This is not about kind of putting SIB feeds ahead of everything else. They have their appropriate place like any therapy area. And I just wanted to flag up that it's easy, even oral nutrition support, the letters ONS is often what we call SIB feed, so it can be a bit confusing. So particularly to the non-dietitians, we thought this would be worth flagging up before we go into Anne's session. So with that clarified, and me having taken more than enough time and some of it talking to myself, and I'm going to hand on to you. So welcome, Anne Holdaway, who's a consultant dietitian, the chair of the very apt role that she's currently taking on of the British Dietetic Association COVID-19 clinical guidance group. So right bang on the money for this session in a sense. And we've had the pleasure of working out with a number of years, and she's, I think, through us and others, got to know the pharmacist agenda quite well as well. So knows what the needs are. So enough from me, Anne. I'm going to hand on to you. Welcome.
Thank you, Shaylin, and welcome to everybody this evening. And great to be a part of this event and be working with I2I and the pharmacists and dietitians who've dialed in tonight on a beautiful evening. I'm just going to mention about the key principles really of nutrition relating to frailty, which is at the heart of what we're discussing tonight, both in the role of the pharmacist and also touching on some of the aspects where dietitians come in to help pharmacists manage patients who are frail. And we know that even in the absence of COVID-19, malnutrition is a significant issue for many older adults in the community. And if you look at the numbers who are malnourished in the UK, we're a fairly wealthy society, but malnutrition affects about 3 million of the population. And just under half of that are those of older age. Now, if malnutrition is undetected and left untreated, it increases the risk of complications, hospital admissions, readmissions, the length of stay increases if a person's admitted to hospital, and it reduces functional status. And these aspects are all important to our patients. We know that they don't want to go into hospital if they can avoid it. They want to come out of hospital as quickly as can, hopefully, and certainly they want to optimize their quality of life. So nutrition plays a big part as we age, and if we've got chronic disease, in making sure that our functional capacity and our quality of life is optimized. But when we start looking at what happens to dietary intake as we age and what happens to our requirements, we certainly know now from knowledge over the last decade that protein requirements increase with aging. They're also increased in those with frailty and with sarcopenia, which is this loss of muscle mass that occurs with aging and also chronic disease and not using your muscles. And often these requirements are increased at a time when many issues might affect and impair the dietary intake of the older population, and particularly those with chronic disease. And just thinking about our older population, and particularly in the time of COVID-19, they are even perhaps more isolated than ever. They're experiencing loneliness. And actually, if COVID-19 then strikes, then we know that many of the symptoms of COVID-19 can further impair their dietary intake. So in terms of malnutrition and frailty, there's a big overlap. If you think about frailty as a reduced ability to deal with a stressor, and then you think about a patient with malnutrition who might be underweight, have a very low body mass index and low muscle mass, then they often can't deal with a stressor either. So we know the two conditions overlap. They're very intertwined and they affect older people and those with chronic conditions, patients who have cancer, patients who have respiratory disease like COPD, and then our patients as well at the moment who are coming out of hospital or coming out of ICU after an episode of COVID-19 that has resulted in severe infection. They're also coming out of hospital quite depleted with loss of muscle mass and quite frail. So I think we've got a question now on the poll, is that right?
We have, we've got a poll coming up. Just going to launch that. Okay, so that should be coming up on your screen now. So quite a spread. Thing to think about. Okay, so and I guess the answers will also be reflective of the mix in the audience as well. So be interesting to see how it pans out. Most of you have voted, so we'll give it another 5 seconds, and then so if you're thinking of voting, make your decision now. Okay, so yeah, so rarely, never, sometimes, the majority kind of are on the less frequent side. And to be honest, given that the audience is majority pharmacists, I would have expected that, to be honest. I think if the whole audience had said yes always, I'd have woken up after a time, or there's a whole load of liars out there, I imagine. But that isn't the case, so I'm not surprised. So interesting. Okay, so hopefully that will change as we go. So yeah, back to you, Anne, for the key guidance then.
Thank you, Shailin. So yeah, so therefore 20% of you are not screening for malnutrition or proactively incorporating malnutrition screening at the moment. So I hope by the end of this session you might consider it, and I certainly hope that dietitians who are on this webinar tonight are very much engaged with the malnutrition agenda and supporting local pharmacists to actually understand the importance of screening and then how to act on that. But hopefully we'll shed some light on that too. But certainly we're aware that around the UK, many of you will have access to local guidance. You will perhaps have formularies in place. So it is all about encouraging you to access that local guidance if you're not familiar with it. Hopefully you have access to some local dietitians who you can call on for support to help you, particularly with complex patients. And the actions about screening and the importance of screening, looking for malnutrition, considering it within your holistic assessments, has really been highlighted by NICE, dating back to 2006, and the quality standards that followed that. So they show that actually if you screen and treat malnutrition, it's highly cost effective, and it's in sort of the list of the top 3 savings associated with the implementation of NICE guidance. Through some work that we did through the Malnutrition Pathway, a group I chair, we recognised in 2011, 2012 that GPs and allied healthcare professionals and colleagues in the community were asking for some guidance on managing malnutrition and screening for it, and that was really the springboard for producing the Malnutrition Pathway, and we'll be looking at some of the resources later. And certainly the British Dietetic Association website has a plethora of resources that are easily accessible for allied healthcare professionals and dietitians alike. And also during this COVID crisis, we've actually given open access to a whole raft of resources to help healthcare professionals and patients and carers deal with nutritional issues during the COVID crisis. So if we take a look at what we might do in normal practice, malnutrition screening in frailty, we normally recommend the use of the universal malnutrition universal screening tool that was produced by BAPN approximately 20 years ago now, where you base your screen for malnutrition on body mass index, unplanned weight loss over a 3 to 6 month period, and whether food intake has been interrupted. And based on the results of that, you then get an overall score, which gives you a risk of malnutrition being either low risk, medium risk, or high risk. But one of the issues that you might face during COVID-19, doing your virtual consultations and not able to see these patients, is that nutrition screening, as we normally do in practice, using must and getting patients to step on scales, may not be possible. So within the resources tonight, we've got some tools which you can access, which include things like the link to the NHS BMI healthy weight calculator. So if you have patients or carers of patients who can access this tool, then it takes you through calculating the body mass index, which then can show if their body mass index is low, and if it is, that's a risk factor and would score 1 on the must screening tool. There's also a link that we've provided to the BAPN malnutrition self-screening tool. So this was developed for carers and patients to use. They can go online and calculate their own malnutrition risk. And then also we wanted to highlight tonight some work done by the Patients Association, which was to produce a nutrition checklist. And I think this is particularly relevant at the moment where we might not be able to weigh patients. Older, frail patients might not have access to scales. We may not be able to calculate their BMI. So the Patients Association put together a nutrition checklist, which allows the patient or carer to answer some questions that identifies whether they are at risk of malnutrition or undernutrition, resulting perhaps from a poor appetite or illness, and then leads them on to what actions they might take. So some of those tools are particularly relevant at the moment for our patients in the community who might be isolated and who we can't actually see in clinics. We've also put together some questions. So in remote consultations, we put together some questions that you might want to consider if you're phoning somebody up or doing a call with them on Skype or whichever you might be using. Some useful questions to ask if patients are unable to weigh themselves. And these very much reflect what is in the Patients Association checklist and also some of the more subjective measures that are embedded within the MUST tool. And hopefully you can build those into a polypharmacy review or encourage the care homes or carers to undertake some of these questions to think, has this patient actually been losing weight and are they experiencing a poor appetite? So if we've established that a patient has a poor appetite, they've been losing weight unintentionally and may be at risk of malnutrition, under normal circumstances, we might have calculated their MUST score. And if you look at the Malnutrition Universal Screening Tool, what you do next is then really important. There's no point in screening if you're not going to do anything with the information. So under usual circumstances, if you find a patient is at low risk of malnutrition, you might be advising them on a balanced diet and undertake some routine screening a little bit later. For a patient at medium risk, so ordinarily they would have a MUST score of 1 if you were using MUST in the community and able to weigh them and record their body mass index. You might go on to give dietary advice and get them to consider self-purchasing an oral nutritional supplement or a powdered supplement from a pharmacy or a supermarket. Now, obviously, at the moment, access to food may be limited and people may not be able to get out because they're shielded, self-isolating. And so we have to think about putting that dietary advice in context at this moment in time. And if, again, we were able to identify a patient is at high risk through the malnutrition screening tool, then we'd look at, we'd obtain a score of over 2 or more, and we might give dietary advice. And often in these patients who are losing weight at quite a rapid rate, we might need to take action and consider an oral nutritional supplement prescription at that point in time and possibly refer to a dietitian. But faced with the issues that we have at the moment in weighing patients and calculating the MUST score, the Malnutrition Pathway Expert Panel identified that establishing a MUST score and knowing what action to take could be really challenging. So what we've put together is a COVID-19 illness resource finder that through questions that prompt whether a person's got a normal appetite, whether they've lost any weight unintentionally, on the actual interactive resource finder, you can hopefully get to the right place to find the right information for the patient that you're dealing with, or the information for the carer. So what you've got on the screen at the moment is a person at home with symptoms of COVID-19 illness, and you can see there are a number of lines. If you click on those, you would get to the specific resource that relates to their particular situation, which might be they've got a reduced appetite, their weight's usually healthy, but they've lost a little bit of weight. And that would take them into the moderate risk of malnutrition and take them onto the right resource and dietary information to support that. If you can move the slide on, thanks. That's just showing you there on that screenshot how if you clicked onto the box where the patient may have lost a little weight, then it would take you to the medium risk dietary advice. And what I'd like to flag up here is these resources have been specifically designed to take some of the symptoms associated with COVID-19 illness, which is things like dry mouth if they're on oxygen therapy, things like breathlessness, how that might need to lead to a change in diet, like a soft, moist diet, and lots of ideas for that. So these resources are designed for you to access whilst you're undertaking remote consultations, perhaps emailing them onto your patients' carers, identifying those patients and making sure they get the right information at the right time. And then it's important to be following them up.
Great. That's great. And thank you so much for that quick introduction. So now we're going to move on to the case studies. And so imagine, if you will, this is how we thought of it, because we want people to kind of think of the polypharmacy medicines, the patient as a whole, really, and given that you know, it's a kind of partly a polypharmacy, partly a nutrition agenda. Imagine on one shoulder you've got Anne when you're in practice, and on the other Lely. That's how we kind of want you to think going forward, which would be quite a powerful combination. So we built the case studies for rather than different sections for both of them, really completely different case studies. We've woven it into the same case study. So with that said, we've got two types of patients. We're literally just going to spend the bulk of the rest of the time. I'm conscious, guys, we're slightly behind, so we're going to have to speed through things a little bit. But the first patient is a frail older person for their essential ongoing care, so not hospitalized, etc., just kind of shielded probably, and how will we look after that patient versus somebody who's clearly had COVID, been discharged from hospital, and what are the needs and how do we manage them? So with that in mind, I'm going to invite Lely first to kind of lead the way from a pharmacist perspective. And Lely, the patient there, you can see the details. So can I hand on to you to just introduce the patient and take us through the case study?
Okay, so thank you again. So we've got a patient here who is coming to see you because who has asked for you to intervene because they are feeling quite dizzy, and they think that's due to their medicines causing side effects. She doesn't want to come into the surgery because she's worried about contracting COVID. So she's currently at home. She has minimum support from anybody, and you can see she's 78, she's a female, she's Afro-Caribbean, she has multiple long-term conditions. She's taking quite a lot of medicines there for her multiple long-term conditions. And we can see her most recent blood test results, which was done in December 2019. So coming to this case, obviously it's not one of my cases, so I'm not going to come up with specific recommendations, but how we need to be thinking in COVID. So the first thing I would say is, before you go and visit the patient, you have to kind of almost prepare, and a lot of that preparation would help you in your short consultation. So you are thinking of conducting a virtual medication review, and Shailene, do you want to move that forward? Yeah. So do you want to run the poll now, or can I do that? Would you do that later on? Do you want to go ahead?
Do the poll, and yeah, we'll just see.
Do the poll and see.
Before you do the reveal, we'll see what we'll have to say on the poll.
Okay, so the first question is, would you consider stopping any medicines or changing any doses? So I'm going to let that poll run for a little bit.
Yep.
And then we'll see what the result comes out.
Yeah, clear consensus forming on the numbers so far. So yeah, I don't know if Lely, on the technology, do you see the numbers coming out at your end?
No, I don't, but I think when it finishes, I will see the numbers.
I feel all powerful seeing the numbers go up.
The power is in your hands, Shailene.
Wait to see them.
Okay, I think we're almost there.
So you'll see them.
Wow. Okay. How interesting. Yeah. So that's really interesting, because I'll go through the case and then I'll see what you people think at the end. So yes, as pharmacists, there is always the need to consider stopping some medicines. And I think if we had the names of drugs to stop, some of you would have already said, stop oxybutynin, stop alendronate, possibly reduce the BP medicines. And I think that's valid. But I think in COVID, we might need to take a step back. So the first thing we need to think is, we shouldn't be making these decisions just based on age. We need to think about frailty. So frailty is still there. We already see that this particular old person has a frailty score of 0.29, which is moderate frailty. So again, this is not somebody who is mildly frail. This is someone who is moderately frail, and all the things that happen with someone who is moderately frail. So the first thing I'd like to think about is, how are we going to conduct this virtual review? What do we need to consider? who do we need to, would we consider any further monitoring? Because remember, I said monitoring is a big thing. And also, do we need to refer anyone? So I'm going to kind of go through those three things together rather than trying to answer them separate. So the first thing we always do is the patient is always the most important. In this case, we have a patient concern. So we're thinking safety, the patient is concerned about dizziness and they don't want to come in. That really needs to be the thrust or the first thing that we address. The next thing, so that's the patient's perspective on safety. The next thing is the pharmacist's perspective on safety. So I just looking at the drugs, I've identified kind of 6 things broadly. So the first thing is we need to reduce the risk of COVID in this particular patient because frail people don't do well with COVID. And so they're high risk. And so everything we need to do around infection control, we need to, when we're talking to this patient at some stage, help to alert them to the signs that they might be having COVID. Just bearing in mind that old people they're finding that old people might have slightly different presentations with just a cough or low-grade fever. So it might not be classic. So again, this is one of the things we need to be red flagging and making sure we have something in place. The second thing I'll be thinking about is around adverse drug reactions. So for example, the risk of acute kidney impairment. So as we can see from the ACR and the creatinine clearance, this patient already has some kind of kidney impairment. And of course, you would have picked that up as pharmacists. They're on ACE inhibitors. They're probably not drinking enough because they don't have, or just because they don't have enough, or maybe they're not moving around as much. So would we need to be thinking about, withholding that medicine or stopping temporary, as we know about sick day rules, because we don't want to get that done. Now, when it comes to monitoring ACE inhibitors, the monitoring data or any of the guidance tells us that when people are using ACE inhibitors for hypertension, we don't need to monitor them once they're stable, apart from just the U&Es probably every year or so. But in this particular patient, although we've seen a kidney function in December, we need to be thinking it's now April and we need to be thinking, what can we do? But this patient is not ready to come in. So the way we need to be thinking is, if we can't get a kidney done, if we can't convince them to get their kidney function done, we need to be asking for signs of acute kidney impairment. So we need to be asking, are you going to have a wee regularly? Is there any swelling? Are they short of breath? Are they a bit confused? Are they having nausea? And so all those things we need to be looking out for, which we wouldn't do because we would normally if we were seeing them face to face. The next risk will be around GI bleed. So again, you probably would have noticed she's on rivaroxaban, she's on citalopram, she's on alendronate. All these drugs kind of increase the risk of having a bleed. If you're taking rivaroxaban and your creatinine clearance is less than 29, you have a 1.6 times risk. So again, with rivaroxaban, we need to be monitoring people's renal function every 3 months. If their creatinine clearance is less than 30, again, there might be a need to do something. I think we are reassured that this particular patient is on a lower dose. If they were on a higher dose, we'll be thinking maybe we need to cut that down because of all that, but they're not. And I think it's back to that same question. If they're not going to come in, if we can't convince them when we see them, we need to be thinking broadly. We need to be asking them about signs of bleed, any dizziness, any shortness of breath. So when you've been bleeding and you have anemia, that can often present as dizziness. So again, remember that this patient has dizziness, shortness of breath. The next thing I'll be thinking about very quickly is around postural hypotension and the risk of fall. So you notice they're on quite high dose of blood pressure tablets. We can see that their blood pressure is 117/72. Again, what I would like to do in practice would be to do a sitting and a standing so we can see whether there's a postural drop, but that's not going to happen. So again, we need to be thinking, what are the signs of hypotension? We ask the old ladies, have they had a fall? Do they feel like passing out? Do they feel faint on standing? So there are many other drugs. There's ramipril that's causing that. There's citalopram, there's oxybutynin and amlodipine. All these things would contribute to postural hypotension. What would be interesting would be to be able to do a test like the timed up on get up and test. But we can't, I mean, it depends on how active the old woman is. If that's a video consultation, you might still be able to do that whole thing if it's safe to do. Next thing, like you probably would have picked up, will be around the anticholinergic burden. So as you can see, the oxybutynin has an anticholinergic burden of 3, citalopram has an anticholinergic burden of 1. We want to know that the anticholinergic burden is not going to cause confusion and delirium. Again, that's a very common thing with old people and COVID, and they go and they have delirium. So we want to make sure that all that's not happening because they're not frail, because they're so frail. Another thing is if they get confused, it's going to affect their compliance and they might start taking their medicines in the wrong way. So all these things are risks we need to be thinking about. The final one is around the dizziness. She's convinced that is caused by one of her drugs. So again, with good history taking, but when I've looked at all her medicines, there are about 4 or 5 drugs where dizziness is very common or too common. And so again, we need to be thinking about if people are dizzy, it increases their risk of falls. So this old lady has osteoporosis, and there's a very, very real risk that she could have a fracture. So we've done all this, and we're thinking about this as we're thinking of going to see the old lady. So when we go and see the old lady, or when the appointment is due, we need to do all the normal things around you do when you're doing remote consultation, is just confirming the date of birth, introducing yourself, very quickly building rapport, reiterating and setting an agenda of what really matters with the old person so that they can engage. So obviously it's the dizziness is the big problem for them. Question would be, old people can say they're dizzy, and it could mean a whole lot of things. Is it that they're not balanced? And so I would say to them, would you describe what that means to me? Is it that they're feeling faint? Because again, that could be due to hypertension. So it's getting a good history. When did it start? Which drug? Is there any new drug? Is there anything that makes it better? A lot of old people say with their dizziness, they sit down and it passes. Is it giddiness? Is there something that makes it worse? And so again, I think there's a lot of that going on. Once we've got that, then we can offer our own view about what drugs we think it might be. It depends on how desperate she's feeling and how unsafe it might be for her to fall and the consequences of that. So you might need to stop something or start. So again, I'm thinking if her blood pressure is low and she's, potentially having hypertension, if she's feeling dizzy and, she's far away from it getting high, we might want to think about that. Depends on what's happening and how much you can convince her to come in, or if there's somebody else there, does she have a blood pressure monitor in herself? So the next big issue will be around the monitoring. If we have to change her blood pressure tablet, it would be nice to have a sense of what that blood pressure is. So again, is asking her, what is the problem, or what is your anxiety around coming in? We might be able to reassure her if she needs to come in and put her at that risk. We might be able to find somebody else who's good. I know it says she doesn't have much help, but she might have a friend next door. She might have, somebody, she might have her own blood pressure thing. So again, it's thinking about that. Definitely, if it seems like she's having all the symptoms of acute renal failure, I will be thinking of the sick day rule, as long as she can have capacity to make that decision, as long as she knows exactly what it is. Finally, we'll be talking about safety netting. So historically, when we see people, we just give them general information. If everything is not working fine, let us know. When you're doing remote consultations, because we're not seeing the patient and all the things I mentioned, we really need to be clear. So for this patient, I would say, for example, if the dizziness gets worse, we really need to pick up on that, because it could be due to anemia, and it might just increase the risk of falling. We need to tell them exactly what to expect. We need to remind them about COVID and the need for them to contact and make contact with somebody if they begin to feel worse off. Can you move it to the next slide, please, Shailene?
Lily, we're going to go to the poll in a second. Interesting question I thought I'd flag up from somebody in the audience. So interested to know Lily's approach to patients on B12 injections, usually given by district nurses. The guidance keeps changing, and NS are trying to reduce contacts. Any thoughts?
Yes. Yeah, I think that is a typical situation where, and I think depends on what guidance you look at. And I think bottom line is, I think it has to be done on an individual patient basis. So it depends. If somebody is really, and I know some of the guidelines have said it really doesn't matter delay. If you have an old person who is really low in B12, that can actually cause a lot of problem. So I would say there's the general guidance generally saying, you know, it's really not that important, but it's really about if there is a district, I mean, if the district nurse is going in once every 3 months, how much is that on their caseload? And what's the risk associated with this particular patient? You know, I've seen people saying some people can self-inject. I think we need to explore everything, but at the end of the day, if the district nurse has to go and visit one patient to make sure that their B12 is up to prevent them from having severe side effects, I think is worth it. I think it's really very difficult to give a blanket approach. So I think the guidelines would be the starting point. I think in care homes is a lot easier, because if it's in care homes, the nurses are already there. And it's slightly more difficult, it's slightly easier than when somebody is at home. But I think it has to be on an individual, you know, case.
Okay, great. Let's go to the poll. So the question you'll see is, what red flags would indicate this patient needs to be seen face to face? A really crucial question in many ways. And I'll just wait to people to answer. So quite a spread. We'll share it in a second when more people have answered. Just getting people to think late on a Wednesday night, so that's good. Okay, we'll just give it a couple of minutes. I think the numbers are creeping up, but it does kind of test you a bit, this one. Okay, and of course we only gave them one choice, I think, so they had to pick one. I'm sure that many would pick more than one, but to know which one is really ringing the alarm bells most. Yeah, so apologies if you wanted to click on more than one, you probably would have clicked on all of them, but signs of confusion seems to be the winner by quite some distance. So yeah, cool. Actually no, more than one.
Signs of confusion. Signs of confusion seems to be the head. I think you're absolutely right. If she's having signs of confusion, I think that's a really important one, because it could be that she has COVID, she's getting delirious. It could be that she has AKI. It could be a whole load of stuff. So for me, that's something we really need to address.
And I've realised that actually you could pick more than one, because unless my math is worse than Diane Abbott's, that you could get that percentage with only one choice. So that's good. I thought it was only one. Apology. So that's even more valuable. Great. We'll move on with that political statement from me. So we're going to hand on now to the same patient, to Anne, to the other shoulder, as I said earlier. To Anne, do you want to kind of take us through the malnutrition aspect for this patient, if you would?
Yeah. Thank you, Shaylin. So I think for this lady, it's quite important. She's described as moderately frail. She's possibly following some dietary guidance and dietary advice that she's been given in the past around her hypercholesterolemia and a type 2 diabetes. She may have been given some advice about her kidney function as well. So she's possibly at risk of malnutrition, and we've already mentioned about the issues associated with malnutrition and frailty. So here you've got a lady who you've got her body mass index calculated in December. So given the current COVID situation and the clinical status, you probably are wanting to ask her a little bit more about her diet and her dietary intake, and whether she's lost any weight recently, and whether there are any red flags in relation to her being isolated and not able to access food. So I think one of the questions with this lady was, given the current COVID-19 situation and the clinical status of the patients, we were going to ask you, would you consider prescribing ONS for this lady?
Just run that part,
yeah.
Brilliant. So this is where the dietitians in the group really come to their fore, I think, but it'd be interesting to see what others would say. And I suspect for a lot of the pharmacists, this is not something that they would currently do. So I'm aware that, in an hour session, we're not going to get you up to speed on that, but we thought it'd be a good consideration to start getting you thinking about it.
Okay. Oh, I'm interested that nearly half would consider prescribing an oral nutritional supplement. And I think for this lady, there's a number of aspects actually. That she's isolated and indoors. I'd probably be wondering what social help she has. Like Lely said, has she got a neighbour? There are lots of schemes at the moment where people have really stepped up to look after elderly neighbours, and I've heard of things locally where people are taking meals round to those who are quite isolated. So, I'd be considering, has she got any social support? How is her appetite? She's starting to have some symptoms. You're worried about the breathlessness, might be a COVID-19 infection developing. So she's one of these ladies who's on the brink. She's got a MUS score of 1 based on a body mass index of alone. And if you throw in some poor appetite and weight loss in her, she's quickly moving into the high risk of malnutrition. So I think this is a lady you'd certainly want to keep an eye on, build in a nutrition conversation into your reviews, ask her about her dietary intake, a dietary variety. We know in frail older people, the greater the dietary variety, the more likely they're going to meet their micronutrient requirements. You might want to ask whether she's got access to all the different types of foods, like protein foods. And because her body mass index is probably just slightly lower than ideal, and she's got type 2 diabetes and hypercholesterolemia, I would begin to think in this lady that you might want to ask her about relaxing some of the dietary advice you might have been given in the past. And you sometimes find that they're keeping quite rigidly to 3 meals a day, and it might be in this lady you start thinking, I might hold off oral nutritional supplements for just now. I'm going to give some dietary advice to maybe get her to increase her intake of calories and see if she can increase her intake of protein without harming her renal function. So there's ideas in the dietary advice leaflet for this lady that as a pharmacist you can access and give her some tips to maybe start thinking about eating little and often, good dietary variety, and maybe some nourishing drinks. So when she's having drinks, thinking about those drinks being nourishing drinks, like a milky drink, for example, which also count as fluid, but keeping a close eye on her. It wouldn't take much for this lady to start slipping into a high state of malnutrition. And also you might want to consider for this lady about getting a sample pack. A lot of the manufacturers of oral nutritional supplements provide sample packs, and given that she's isolated and at risk and it wouldn't take much to tip her over to become more malnourished, it might be that you could provide a sample pack of oral nutritional supplements, so she's got a little backup to get them started should she find her appetite deteriorate. So yeah, so that's what I'd be considering here. So there's no cut and fast rule about whether you'd want to initiate oral nutritional supplements straight away in this lady. That there's, in the COVID situation, the issue that we might recommend self-purchase of oral nutritional supplements for somebody like this. And at this moment in time, being isolated, that might not be so easy. So I think you'd through a more detailed discussion with her, you might go either way, really. So yeah.
And can I just very quickly flag up a question? Good point. A couple of dietitian-based questions I think are here. What is the role of protein-based sit feeds in patients with poor wound healing is one, and then the flip side of it, the same issue. What are the protein restrictions in CKD?
Okay, so in terms of chronic kidney disease, the dietitians have access to guidance around protein in these patients. What we often find with older frail patients with multiple morbidities and chronic disease is that actually if you look at their dietary intake of protein, it's way below requirements. So there's often an option to even use a high protein supplement in somebody where you think they've got loss of muscle mass and it's not known to deteriorate their renal function. So I think it's important in this lady. I perhaps wouldn't use a high protein oral nutritional supplement in this particular case. I think you'd use a more balanced one. And I think when we come on to case 2, we'll exemplify there where we might be looking at a high protein supplement.
Great. Great, very quick one, because I think you'll be able to put this to bed for us quite quickly. ONS is only on drug tariff for malignancy, question mark, not decreased appetite. So if you could just clarify the approved uses.
Yeah, yes. Yeah, so for the ACBS indications, you've got disease-related malnutrition.
The key one.
Yeah, is the key one really, that would cover an awful lot of conditions. You know, you can't prescribe these supplements for social malnutrition necessarily. You could discuss that with your GPs and your CCGs if it was really needed, but on the whole, you're looking at these supplements being used to address the nutritional deficit that can arise through disease-related malnutrition.
Brilliant. So guys, keep the questions coming in. There are a few others. I'll pick up the odd one along the way. We will stop at the end to answer the question. Otherwise, we'll never get out of the first case study. So if we can just ask both of you, left and right shoulder, if I can refer to the two of you as that for this evening. Quick summary of top tips so far. So Lely, you first on the medicines.
Yep. So just going very quickly. So priority is safety, reducing immediate risks rather than the long-term medicines optimization. So we can do the prescribing if it's posing an immediate risk or if there's a safety issue around that. We still need to be very person-centered care. We still use a person-centered care approach. What matters to the patient is really important, including shared decision-making. We need to prescribe cautiously where there is a low risk, particularly in people who live on their own. And then we need to start with the evidence base, using what we already know and just tailor it to the individual frail person, and also tailor it to the situation around the COVID and reducing the infection. Safety netting is very important, and monitoring and follow-up is often needed.
Great, thank you. And the same question to you, Anne.
Yeah, so best practice tips for me would be, you know, just checking with them, have they got access to food while they're isolated? There are store cupboard ideas on the British Dietetic Association website, really great resource. It's included in the malnutrition pathway COVID resources as well as an embedded link in some of the guidance that you can access. You know, I'd look at can she act on any recommendations? The thing is, as Lely said, it's that patient-centered care. What matters to her? Is she really concerned about her dietary intake? Is she anxious about her diet? Yeah. And does she feel that some of the dietary advice given before is quite restrictive? And in this lady, is it a case that some of that could be relaxed a little bit? And yeah, I think the follow-up phone call, building that in a timely manner in somebody like this. That would be my top tips.
Brilliant, thank you, both of you. And we're going to move on to the second patient. Just before I do, because we spoke about vitamin B12, somebody has helpfully posted a bit of advice. British Society of Haematology guidelines are nice and simple to follow for B12. So thank you for that. So please do look at those if you're interested in vitamin B12. We're going to move to the second patient in the case study. So quite a different scenario, post-hospital discharge, virtual follow-up still, and the same combination, medicines and malnutrition. So let's stick with the winning formula. Here's the patient. Oops, sorry, went too fast. And then if you want to kick us off on the medicines first.
So this is really interesting because we have an older patient, and this actually, but just kind of reiterates the point I was saying, that it's not really about age, it's about frailty. So we've got a gentleman who's just been discharged from hospital post-COVID. He was in ICU for a while after testing positive for COVID. He was previously fit and well, and now that he's come out of hospital, he's kind of moderately to severely frail. And that's just because he's had the ICU acquired weakness. And again, this is quite common in people who have come out of ICU. They have myopathy, they have functional inability, something that's called deconditioning. So where people, because they haven't been kind of active for a while, that there's muscle waste and all that going on. So because of the lockdown and obviously his isolation, he has minimal support. So again, same thing as the other person. Like I said, he's slightly older, he's a male, he's South Asian, lives alone at home, essential hypertension and hypercholesterol, glaucoma and CKD on discharge, CKD2. So his kidneys suffered a little bit. Smoker, and he has all these medicines, not that many medicines. So two blood pressure tablet, one for his cholesterol and his eye drops for his glaucoma. Nothing really alarming about his results. A bit overweight, but not that desperate. And his blood pressure is 132/88. So do you want to move to the next slide, Shalene?
Okay.
Thank you. Yeah. Do you want to do the polls?
Yes. So let's go to the next poll.
Yep.
We postponed follow-up blood test monitoring in this patient. We're just going to launch that for you. One this time.
Yep.
Well, simple options, not a simple question, perhaps.
Yep.
Okay, so clear consensus forming on that one. Big majority, yep. Yes, they would.
Yes, it would be interesting to see to think about the reasons why people thought maybe they wouldn't postpone it. So it's really interesting because, again, different to this old lady, we have this guy, all his blood summary are kind of quite recent. If you look through, majority of the things there are within normal range. There is nothing he's really taking that makes us desperately want to monitor anything right now. And I think I would postpone whatever needs monitoring. I'll go that into detail. The focus for this gentleman is rehabilitation, getting him a bit more mobile and active, and recovery. So we want to get back his function. He was an independent man. If we don't get him there slowly and steadily, he might get depressed. He might, because he was an active man before this time. We need to get his respiratory function back. And one of the things that people suffer a lot is the breathlessness, even after they've had COVID. So we know this guy he's a smoker. So again, we need to be thinking about smoking. Is it still safe for him to smoke? Not just from the breathlessness, but if he hasn't been smoking, might this be a good time to just carry on? What are the risks if he has all this muscle weakness and he's smoking? Is that a hazard really in terms of his environment? Another thing people suffer a lot from is fatigue and pain. So we know this is a gentleman who, from COVID, he's going to have this myopathy. He's already on atorvastatin. I'll be thinking down that line. What are we? This primary prevention. What is this for there? So I will be looking at considerations there. We have his cholesterol. Is this something that we might just need to hold up for a little bit, even if we don't stop it permanently? If he's in pain, we need to think about things like over-the-counter paracetamol and how he gets that. And just who's going to do that delivery. We might need to speak to our community pharmacy colleagues if they might be able to help with that. We need to think about the safety in the home environment, falling, especially if his muscles are wasting. I'm sure Anne will have a lot to say about his dietitian, his food. What a postural hypertension. Again, he's taking 2 blood pressure tablets. Do we really need that? But again, just mindful that his blood pressure is not as low as the other old lady. What's going to happen if he's 83, can we kind of push things into the 150s, 160s? How safe will that be? So it's thinking through all that. We know that polypharmacy, 4 or more medicines, irrespective of what drugs they are, they increase your risk of fall. So again, I will be thinking about, has he, I would ask him questions like, is he experiencing some of the signs of hypertension? Because you can still have postural hypertension, even if your normal blood pressure is okay. Old people and frail people do have that. Also be thinking about medicines reconciliation. So around medicine safety, the most important things, does he have the right medicines? Can he administer them? And would he adhere to them? Is he able to? So stripping things down, doing a medicines reconciliation, checking what's on the discharge form and checking what his awareness or his recollection of what that is. And for me, I think is really important. How does he get adequate supply? We don't want his glaucoma to get worse. So again, it's linking with the community pharmacists and the volunteers and the whole delivery thing. Can he self-administer his eye drops and his medicines? Is he aware? Can he got the grip and all that? So again, it's whatever we need to do. Who else is going in? Who else can we ask him to depend on to depend on for whatever he's doing. I think that's about, oh, I was going to talk about, I've spoken about the smoking cessation, so that's fine.
Okay.
I think that's about it, yeah.
Great. Lily, I'm going to suggest in the interest of time,
Oh, sorry.
We'll skip.
Yeah, sorry, I just wanted to say about the aspirin.
Absolutely, go ahead, because I'll skip
I was just going to talk about the aspirin. That's the one medicine I would say we can stop without any problem if he's happy about it, because there's a real risk of bleed. It's primary prevention. He's 83, he's moderately frail. I can't see, I think in that particular case, unless the patient is desperate not to stop, the benefit definitely and the risk definitely outweigh the benefits.
Okay, let's keep rolling then. So we've had same patient, and over to you, Anne, with the nutritional aspect here.
Okay, so having been having weekly meetings with the BDA COVID-19 clinical guidance group, this gentleman who's 68 and has come out from hospital after an ICU stay is fairly typical of the population that have been admitted to ICU and had a considerable length of time on ICU when severely affected by the COVID-19 infection. So with this gentleman, what we're tending to see when they're in hospital is that they're mechanically ventilated for 1 to 2 weeks. It's very difficult to provide the nutritional support to meet their requirements because of the need for proning in hospital. And actually when they're discharged to the wards, they may be on wards where the staff are unfamiliar with managing respiratory patients. Often the nasogastric tube feed that might be still needed in these patients is somehow being taken out, perhaps a little bit early, as they go to the general ward. They're then reliant on oral intake in a ward where there may be staff working who are unfamiliar with the routines. And so the nutritional status of these patients continues to deteriorate potentially after their ICU stay. So Lely's also already mentioned about the significant muscle loss that we see in these patients who are heavily sedated at the moment on mechanical ventilation for up to 2 weeks. They then go to the ward, their oral intake may be still impaired because they're breathless, and they're also often still receiving respiratory support in some form like oxygen therapy. What's interesting to note about this gentleman, which is again quite typical from the ICNARC data, which has looked at the data that's been collected, looking at the profile and demographics of our patients coming into ICU with COVID-19, is that many of them, and you might have heard about this in the press, are overweight or obese. Many of them are actually morbidly obese. And I think sometimes the myth out there is like, well, these patients are really overweight, so you don't need to worry about their nutrition. The fact is we do need to worry about their nutrition. They become extremely frail and very sarcopenic following a couple of weeks in ICU, and that rehabilitation, particularly after things like acute respiratory distress syndrome, can take up to a year. So certainly in somebody like this, you've got a body mass index of 30 kilograms per meter squared. You might think, oh, he's overweight, doesn't need nutrition support, but look at his MUS score. His MUS score has been calculated as 2, but he will have had very significant muscle wasting. He'll be very fatigued. We know with COVID, they remain hyper-inflammatory for 6 weeks, possibly more. We know that with that goes a poor appetite, and so it's very likely this gentleman's come home with a really poor appetite. He normally lives alone. He's probably not feeling that motivated to make up meals. So for this gentleman here, he is the ideal candidate for providing ongoing oral nutritional support, and this is the sort of patient we would look at a high protein nutritional supplement in. We may not have to worry too much about the calories if he's got a reasonable appetite and he's starting to pick up, and that's something we don't know at the moment in these patients, is after an acute episode of COVID-19 and an infection, does their appetite pick up reasonably well? This gentleman probably had a good appetite in the past because, you know, he had a body mass index of 30 or more potentially previously before his hospital admission. It's now at 30, but he's probably got a very poor appetite, poor intake, and we know their nutritional requirements for these individuals are raised persistently for a number of weeks, if not a number of months. So I would expect this gentleman to be discharged from hospital on oral nutritional supplements, likely as not high protein, low volume. I know there are various formularies in place that look at switching patients onto sort of lower cost options and perhaps not high protein ones. But I certainly think for an individual like this is the gentleman who would qualify for that. You might be wondering, in somebody with an eGFR of 67 and questionable renal function, should we be concerned? I would say we ought to be monitoring his renal function when he comes home, but often with these patients, their intake is persistently seen to be quite low in the first couple of weeks after discharge from hospital. So his oral intake from his protein and calories would be quite low, and the supplements I wouldn't anticipate would be really harmful, even a high protein one, in individuals like this. And there is a systematic review from Abby Corwood and colleagues that looked at the fact that patients with poor renal function but poor appetite and who are malnourished, you can safely give the high protein, low volume oral nutritional supplements. And if he's struggling with his appetite, then he's not going to manage the larger volumes. He'll need the smaller volume, more compact style of oral nutritional supplement to make up for those significant deficits in intake throughout his hospital stay, and what is likely to be a poor appetite going forward. And he'll probably still have quite a dry mouth and breathlessness and limited mobility on discharge. So he might also need some social support as well, just to make sure that he's actually eating and drinking.
Great. And we're going to go to the poll. Good point to our audience. What they think. And while that's running, we've got a question: should all patients started on NOS be referred to a dietitian? If you could give us a succinct answer in the interest of time on that one.
Okay, should they? In an ideal world, I think it'd be great if every patient who needed an oral nutritional supplement could see a dietitian, because dietitians are able to tailor the ONS to the patients and obviously give very detailed dietary advice. In reality, 3 million patients at risk of malnutrition, patients leaving hospital, possibly not seeing a dietitian. I think that's why we need to work with other members of the multidisciplinary team to actually ensure that patients are reviewed, but provide clear guidance to our colleagues as dietitians as to how they might monitor these patients and measure the outcomes against some patient-centered goals.
Brilliant.
So yeah, that's my view.
It looks like you've convinced the audience, and massive 97% saying yes. Otherwise, I would be saying, where have you been for the last hour or whatever it is? But so it's good to, but I'm very conscious at the same time. There's not something that particularly the pharmacists in the group are used to initiating prescribing. But you know, things have moved so fast. We've got a whole bunch of pharmacists prescribing and changing anticoagulants, warfarin, and so on. So it's I won't say it's easily doable. It is doable, and I'll refer any pharmacists who are interested. We haven't really equipped you. It wasn't the plan for today, but there is another resource, a recording, a series of recordings that Anne has been involved with to get you to be able to manage this proficiently as in your role as pharmacist. So I'll direct the audience to that later in just a couple of minutes. So I'm very conscious of time. People are staying on right to the end. So. Yeah. If I can just and get you to just finish on this, and then we'll wrap up with both of you with kind of key messages. So 5 steps to the right ONS.
Okay. So this was so this was put together, and I would hope for the pharmacists on tonight that actually you might take a look at this afterwards. It's a build-up slide. It was designed because pharmacists that we've worked with I2I and with Lely before have said, well, how do I determine if I'm responsible for perhaps initiating an oral nutritional supplement in a patient who's at high risk of malnutrition? How do I know whether I'm going to provide the right product? So it's a really sort of walkthrough guide. This is a build-up slide. So first you'd look at the level of malnutrition according to MUST or some of the prompts in the resources for COVID. And then you'd look at, well, will the patient struggle to make a powder? And there's some really interesting data showing that in Northern Ireland, where they audited this, only 7% of patients was a powder either clinically appropriate or could be made up. And we know during COVID, patients might struggle to make a powder because they can't access the milk, or they might not be physically able to do it. So bear that in mind in this current situation. Will they struggle with a large volume? If yes, then think about the lower volume supplements. And then finally, have they got other conditions that would increase their protein requirements, like a recent stay in hospital or a stay in ICU? If they've got higher protein requirements, you might be looking at a specific high protein supplement. So then you go on to further information on the table that will hopefully guide you to choose a product that may be available to you within your formularies and the guidance that you have locally. I would always recommend that you work with your local dietitians here. They may be working on the formularies with your CCGs. And if a patient comes out from hospital on a specific oral nutritional supplement where a dietitian has been involved, then I would urge you, I've been on the receiving end of that, urge you to consider, what was the clinical rationale, and ask the dietitian in the hospital why they made that decision. So that either that decision about a specific oral nutritional supplement could be respected, or otherwise renegotiated with the patient and the CCG about why you might be wanting to switch the patient onto something else within your formularies, perhaps because it's lower cost.
Great.
So it looks quite complex, but yeah, hopefully you can work through it.
Yeah, just a perfect time to remind people that the slides, especially the pharmacists who are I2I members, the slides will be available on the development site section in the I2I website, because that's a lot to take on, obviously, and you don't necessarily want to sit through the recording all the way to get back to this point. So you'll be able to access the slides as well. Just a couple of people have asked the question, so I thought I'd throw that in. Great. So if I can, thank you, Anne, for now. For both of you, really, you've taken us through a heck of a journey in a short space of time. I'm conscious of time, so people are, I think, are staying on just kind of for the close, as it were. Summary of best practice, top tips. Lily, for you first, to keep the back.
Yep. Thank you. As rehabilitation is important post-COVID, it's a long journey to recovery, so we need to support with medicine supply and administration. We need to manage the post-COVID syndrome, which is about the leg and the pain, the fatigue, and all that. Safety and reducing immediate risk, same thing. Actually, medicines reconciliation to find out exactly what the patient is taking compared to what they should be taking is more important than worrying about de-prescribing if it's not bringing a risk. Patient-centered care, same as before, shared decision making, and same thing as the safety netting and monitoring, and follow-up needed for ongoing long-term conditions as the patients begin to come out of recovery. So this gentleman is keeping up with his glaucoma and making sure that all those appointments are coming up as he recovers and goes back to what he was before.
Great, thank you, Lily. It's been great. And the same ask for you, Anne, if you would.
Yeah, so I would question if his renal function is down to running in pretty dry, which they've been doing with these patients in hospital. Is it improving? Because that will influence the dietary advice. Is very sarcopenic or likely to be. There should be a focus on protein for these patients, particularly somebody with a high body mass index. You might not be wanting him to regain weight, but you certainly want him to be regaining and building muscle to overcome the frailty and improve his quality of life. I'd want to mention there that nutrition and nutritional therapy should be combined with physical therapy for these patients. It's really crucial that they do resistance training or resistance exercises in conjunction with meeting their protein requirements that are high and continue to be high in these patients for several months. You might want to relax previous dietary advice if his appetite's poor, he's got a history of hypercholesterolemia. I'd say with all of that weight loss, you could certainly relax some of his dietary restrictions while his appetite is poor, and you'd want to explain the reasons behind that. And he'd certainly need to have input for support at home with meal provision or shopping. He might have been given oral nutritional supplements to take home with him, but some hospitals are actually not providing those because of a concern around infection risk and taking the infection out with them. So that needs bearing in mind. There may be a call for a prescription for oral nutritional supplements for a gentleman like this, and he may not have actually come out with any, so you might have to expedite that as a pharmacist in a practice, or otherwise see what he's been given and continue with the prescription, because he's likely to need it long term, and for a minimum probably of 12 weeks in somebody who's had an ICU episode. And ideally this gentleman should remain under dietetic care, so it's looking to see, has he, but we know in the COVID-19 pandemic, we know patients are being discharged without that follow-up. There should be access to dietitians, particularly for somebody like this, to consider him quite a priority. So I would then liaise with the local dietetic department to see, has follow-up been offered, and in most cases now that's being offered virtually.
Brilliant. Thank you, both of you, for such a insightful couple of presentations. So I'm aware of time, so I'm going to take us to the close. That's been really fantastic. We haven't managed to answer all the questions. I think we have the majority, but we will get to them and we'll send an FAQ out. So apologies if we haven't answered the question. I think some of them have been answered along the way. I just wanted to also flag up that those of you that are members, which is all the pharmacists now, I mentioned earlier in the presentation that Anne had kindly done some recordings. We'd recorded this for a project we're running in the south of England, and the content is really much more detail around prescribing ONS, etc. And what we thought we'd do is make that available to really the wider I2I audience. So as you become members to join, if you weren't already, you can see the screenshot of the website on the I2I. You can go in and there's quite a lot more detail. We've also got some case studies, very pharmacist-oriented, polypharmacy-based, combined with the nutrition, very much in the style of what Lily and Anne have done for us today. So please do go in and work through those. You've also got some questions to answer. That should help you to take a big step if you are interested and kind of motivated. Now, I hope you are, to incorporate the medicines with the nutrition, so it really is an enhanced role as a pharmacist. We'd love to see you on there. Also coming very soon, in about hopefully a month, we're, like the rest of the world, shifting the I2I content onto a much more online presence. So again, with the support from our sponsors for tonight, Nutricia, who I should thank really for being with this journey for a number of years and supporting pharmacists, and incorporate this in the main, but also hopefully adding value now to other healthcare professionals. We're thinking in about end of this month, maybe early in the next month, we should have a whole program that's online, so including presentations again from Anne and Lely recorded. So it's really the next best thing to doing a whole day live, but you'll be able to do it in bite-sized chunks without also having to take time out. So you know, some good has come out of the COVID situation, with forcing people like us to chunk things up and make things available to you guys in a different way that's easier to access. So look out for that. And in the same spirit, we're doing another session in a few weeks on AF. Again, it'll be online recordings of presenters, experts, in a similar vein to the two guys you heard from today. So please do look out for those. I think we've covered all of this. I'm not going to do death by repetition at the end of the night. I hope you've got some use out of the learning by focusing on those patient groups. Questions I think we've taken as we've gone along, so it just reminds me to remains for me to say that when you exit, there's an evaluation survey. Please fill that in, because this is all new, and we're kind of learning and basing it on feedback. We've got loads of feedback, very positive, but also constructive feedback on the previous session in diabetes. Please do give us your thoughts. The FAQs I mentioned are available, and if you haven't done that, a lot of the resources, which I'll just flag up in a second, in the handout, if you click on the handout section before you log off, you're able to download that, all the links to all the resources that have been mentioned, which are plentiful, and will give you information about the recording. So it just remains me to say a big thank you, Anne, again, and Lely. Pleasure to have you on board. Thank you. These guys have given up time late in the day, not just today, in the run up to the content, worked at midnight to get this content together. So on behalf of the audience and on ourselves, thank you. You really are a couple of heroes anyway for me, but
thank you.
Stepped up to the plate for the audience. And of course, massive thank you to the audience. So many of you have given up a big chunk of time on late into the evening. So hopefully you kind of got what you came for. Speak to you all very soon and stay in touch. And thank you. Have a good evening. And most importantly, keep safe. We'll see you all very soon. Thank you.
Thank you very much.
Thanks.
Thank you.
Bye. Bye. Bye.